So I'm just going to introduce our last speaker now, and thank you all. And I also just want to bid you all farewell too, because I need to go and catch a plane. So I'm going to be leaving after I've introduced Dr. Jeffrey Hergenrather, who we have heard several times this weekend. He's made a wonderful contribution. Assertions versus evidence is his topic. Jeffrey is an MD, is a general practitioner, specialising in cannabis and cannabinoid medicine since 1999. His medical experience includes 26 years in emergency medicine and private general practice that includes the use of cannabis since 1977. He continues in an active consultation practice in Northern California with face-to-face, telephone and online consultations for the use of cannabis as medicine. So please welcome a wonderful man, Dr. Jeffrey Hergenrather.
Well, thanks so much, John. It's great to be back here. I think if we have the right number of people, if we have over 150 people, we'll have a free pizza ticket for you at the top of the stairs on your way out. Just kidding. Anyway, this is a little turn. Before I start into the topic, I wanted to just say that at the end of our last session before lunch, I'm working with a group of nurses and other people at Sonoma State University. And the nurses are very active in California and around the country in California. The ACNA, the American Cannabis Nurses Association, is educating nurses so that they're confident about how to advise people with the use of cannabis. And so this is the thought at Sonoma State University, is that here's the nurses coming through the nursing program. They want to understand what they're doing. And so I've been asked to help participate, really to chair a course in medical cannabis so that the nurses will have that kind of training. And included in that project is the fact that I'm busy with a dementia practice where I go out and see people in nursing homes, and we're evaluating people by giving them THC-rich cannabis products or balanced THC CBD products by and large, sometimes CBD alone. And then we're using the Cohen-Mansfield Agitation Index, which is looking at 29 agitated behaviors over a course of time where they occur none or they occur hourly as far as these agitated behaviors. So we're able to monitor quite closely the benefits that we're getting with the cannabis therapy. And then we're giving something to the patients 2-3 times a day, usually as a tasty chocolate, describing to them, here's your medicine. What is it? It's your cannabis medicine, and they take it gladly. And then only in the situation that they're too sleepy do we hold the dose. So I just wanted to let people know that we are making an effort to educate the nurses and that we are using it with quite a lot of success in agitated dementias. It's great for all the agitated behaviors. So, assertions versus evidence. You've seen this before. You know, we choose the evidence that really serves our needs, and some of us will look at things like the ancient sources, the Central Eurasian tombs, and knowing that cannabis is in these tombs and was used thousands of years ago. You've heard in the talks up till now that William O'Shaughnessy was a physician, Scottish-born, Irish-born, Scottish-trained, who went on to India early in his career in the 1820s and studied cannabis and then began to write about it for the Western literature. From 1839, when O'Shaughnessy's papers first began to appear in the press in London, until 1972, one of my mentors, Dr. Todd McArea, combined all of those research papers into a volume that he calls the Marijuana Papers. And it's quite instructive as to what we've known about cannabis use in this century and almost a half as far as the medicinal uses of cannabis. And then, of course, we had the Anslinger-Hearst Reefer Madness era, and that led to some responses by the LaGuardia Commission in New York, which didn't believe Anslinger, so they went about their effort to say, well, let's look into this ourselves. And they did report in 1944 that cannabis did not cause violence. Cannabis was not the evil weed that Anslinger made it out to be. And then all that was repeated again during the Nixon administration when the Schaefer Commission looked at the same issues, and their conclusions were you can't distinguish patients using cannabis from anybody else in society. And that's certainly the case in my practice, where I've got doctors and lawyers and professionals of all kinds, law enforcement officers, even Superior Court justices are using cannabis on a daily basis for their medical problems, and they're indistinguishable in our society. To think that they're impaired by this and can't practice their line of work is just, it's quite ludicrous. We've got the IND program that was begun in 1978. This stands for the Investigational New Drug Program. When the feds have a product that they don't want to really allow to be used, they put it in the IND program. So this is where cannabis came to surface in 1978, first with Robert Randall over his glaucoma. He was losing his vision. He's getting halos around his visual fields, and then he smoked a little weed and the halos disappeared. And he was so encouraged by this that he grew pot, got arrested, went into the federal courts, and eventually beat the charges on medical necessity. And from that point on, it began this IND program, which actually then had to provide the cannabis to him. So for the next 25 years of his life, Bob Randall was getting a tin of marijuana cigarettes from the farm in Mississippi, the federally produced cannabis. So this program was closed by George Bush Sr. with, quote, no scientific value to marijuana. Well, they never analyzed any of the 19 patients that were in the program. They authorized 19 patients to be receiving the free marijuana, but they didn't want to know the results of the marijuana use. So it's easy for George Bush to simply say, no scientific value to marijuana. Disingenuous, but that's the way our federal government works when it comes to cannabis. Of course, the feds perennially refuse to reschedule cannabis, and that's basically what we're faced with now. This is a long history of misinformation coming from the federal government in order to support the ongoing prohibition. Otherwise, it simply does not make sense. All of us would say, it doesn't make sense. I don't get it. Why are we doing this? Well, it's about the money. Institute of Medicine came out in 1999 with a book called Assessing the Science Base. This was useful, and it kind of gave a hint to the fact that there were people in high places in the federal system. They weren't really federal employees. The National Academy of Sciences and the National Academy of Sciences and Engineering and Medicine is a private organization, but it's in direct consultation, if you will, with the NIH to do these reports. So this NASEM report, which you've heard spoken of a couple times, Simon Ackerman talked about it a bit on multiple occasions, about this latest book that came out called The Health Effects of Cannabis and Cannabinoids, and their recommendations for research. And this honestly bugs me a little bit. And the reason I say that is, even though it's a step forward from where we've been in the past, it's still looking at cannabis as a drug of abuse and a drug of danger. And I'll explain a little bit more as we go forward, because they've narrowed the acceptable research so much that they're not looking at the bigger picture. And so they still say there's just not enough evidence, just not enough evidence. We've been hearing there's just not enough evidence for generations, and there is ample evidence. And so I'm here to break down a little bit of this, the assertions about cannabis and what the evidence really shows. Some of this is based on clinical evidence, and our last speaker is certainly top of the list as far as people where the clinical evidence is really very compelling. Just the facts, I don't need to elaborate on this. I said it yesterday. There's a ton of information out there. Some of it's animal studies. Some of it's tying off blood vessels to the brains of animals in order to induce strokes. And then you turn around and give some of those stroke patients lab animals, a dose of cannabinoids. And what you find is that the stroke volume is markedly reduced. So this kind of information isn't acceptable evidence to the National Academy of Sciences. It's animal research, and they only want to have these very narrow human research studies. But of course, you understand at this point, we aren't allowed to do the clinical studies. So the things that do make it through into scientific literature are those that are funded by NIDA, the National Institute on Drug Abuse, which is basically looking at the potential harm of cannabis use. You've seen this before. I don't need to elaborate. You've seen this before. Here's where the receptors are. You've seen this before as the CB2 receptors around the body. And you've seen this before as well. The modulation of the endocannabinoid system may have therapeutic potential in almost all diseases affecting humans. And the list of pharmacologic actions you've seen before. So what are some of these assertions? The gateway theory is still an active push by the federal government to suggest that people using cannabis are going to go on to other worse, heavier duty drugs. There's pulmonary harm asserted. There's even the suggestion that smoked cannabis could cause cancers of the lungs. There's a lot of information out there suggesting that there may be brain injury to the developing brain. There's still information about addiction and psychosis and schizophrenia, and of course impairments, particularly in driving. And then the suggestion, at least, that there's fetal and neonatal harm. You know, who wants to be against caution around the babies? Of course we want to be careful, but there really is no significant evidence to show there's harm. But the assertion is that there may very well be harm. So we shouldn't be allowing cannabis or recommending it. So we have a weird situation in the United States now where a mom may come into a hospital in, let's say, Mississippi, and they test her for her urine on admission for cannabinoids. And if she's positive, they're going to test the baby once the baby's born, and they come in, put the urine bag on the baby, and once they've got evidence that there's cannabinoids, actually metabolites of cannabinoids in the urine of the baby, they take the baby away. So this has gotten to be quite disturbing as to the way the government is pressing with the drug war. It's very fearful. So on the gateway theory, this is a paper that came out in 2011 from Van Gundy and Rebelon. Our test of the gateway hypothesis finds 3 conditions under which the apparent effect is disconfirmed. And they kind of break it down into ways that all really run together. Teen stress and life course variables seem to account for the bivariate link between cannabis use and young adult DSM abuse of other illicit substances. Basically, they see kids using cannabis in their youth, and then they see them stop using cannabis when they get into their 20s. The next line was cannabis gateway effect on the use of other illicit substances appears to depend on the variables derived from life course perspectives. Well, what does that mean? I'll get to it on the next slide. And early marijuana use does not elevate the risk for use of other illicit drugs among young adults who are employed. So as the kids get on into their 20s and decide they want to have at least a job to put gas in the car, then they don't seem to have this problem with drug abuse. Marijuana gateway effect appears to be contingent upon age. They say that in this report, the teen marijuana use doesn't increase illicit substance use among respondents 21 years or older. So again, the kids grow up, if you will, and don't really actually have trouble with this. This is way more detail than I would like to cover, and it's almost subjects that I hate to even bring up. But when they look at this gateway theory concept, the kids that are using the cannabis are often the kids that have had these kinds of traumas in their lives. So what I'm saying is, you know, we really shouldn't be blaming the ills of our society on the cannabis. It's a convenient target, but it's not really appropriate. Risk of smoked cannabis on the respiratory tract. I'm suspecting most of you have seen this already, but Donald Tashkin is the professor emeritus of pulmonary medicine at UCLA and has worked for National Institute on Drug Abuse for 45 years in an effort to find harm in smoking cannabis. He does say that smoking causes irritation, inflammation, edema, and increased mucus production in the respiratory tract. Period. No evidence of clinically significant alterations in pulmonary function studies. I've asked Dr. Tashkin a few times if I should just go ahead and set up the respiratory testing in my office, and he says, no, we've done that already. There is no change in the pulmonary function tests in the people that are smoking marijuana. There's no substantive evidence of any increase in the incidence of cancers in the lungs, trachea, larynx, pharynx, or esophagus, even in the heavy cannabis smokers. This is a paper that came out, Hashibi is the way I pronounce it, but Tashkin and he published this in 2006, and it has been really the largest study done to this time in the world, and it's quite evident that risk of pulmonary cancers or other cancers that are associated with smoking do not occur in cannabis smokers. Steve Sidney is another researcher who spoke in front of the Society of Cannabis Clinicians about 2 weeks ago. He wrote a paper back in 1997 that was very interesting because they looked at 64,855 patients in the Kaiser Permanente system. And then they asked them, among other things, were they smokers, tobacco smokers, pot smokers, or non-smokers, with the thought that they would be able to be teasing out any differences in the way that cannabis was affecting these people's lungs. So at least in the risk of lung cancer, really for all cancers, there was a decreased risk of cancer in the cannabis group. But in the lung cancers, the tobacco smokers had 46 cancers over this period of the 6 years of the study period. The non-smokers had 2 lung cancers, and the marijuana smokers had none. This surprised Dr. Sidney. You know, he thought that was quite relevant, that heavy pot smokers were not developing lung cancers. What about brain injury? We look at the cognitive and short-term memory, we look at the effects on IQ and grade point average, and we look at the effects on brain structure. This is something we've talked about in the last couple days. On short-term memory impairment has been observed after heavy chronic recreational cannabis usage, but virtually disappears after a few weeks of abstinence. This is an older paper. No residual effects on cognition. As hypothesized, the meta-analysis conducted on 13 studies evaluating the users after at least 25 days of abstention found no residual effects on cognitive performance. So the suggestion that we do damage our brains and have IQ and cognitive problems and memory problems just does not hold up to the scrutiny of the tests. It says that these results fail to support the idea that heavy cannabis use may result in long-term, persistent effects on neuropsychological functioning. This was a test more recently by Schreiner et al. In 2012. After abstaining from cannabis use, 33 adolescents did not differ in IQ, attention, memory, or executive functions compared to non-users. And previously reported neurocognitive deficits may be related to other factors, including residual drug effects, pre-existing cognitive deficits, concurrent use of other substances, and psychopathology. So again, more evidence that there are other reasons to explain neurocognitive deficits that really are not related to the cannabis. On another page of these findings, lower grade point averages associated with persistent cannabis usage in high school pupils lost statistical significance when controlling for concomitant alcohol and tobacco usage. The government likes to roll these together, tobacco, alcohol, and marijuana, and then they come up with bad reports. And if they really tease apart those three, they're seeing harm in tobacco and alcohol, including adverse outcomes in infant deliveries, but also the cannabis does not seem to be associated with any of these lower grade point averages. And quite honestly, in my own practice, when I'm seeing patients for ADD and they're coming to me as a young teen, for example, I demand that they bring in their grade point averages. And usually I'm finding lousy grades coming in to see me, D's and F's a lot of times, and that in subsequent visits they're coming in with good grade cards after they begin to use cannabis. So I'm certainly not seeing what I would describe as lower grade point averages. If anything, it's better. And here's another line from Mokritz saying that IQ or performance differences in teens were not found associated with cannabis users, again, as compared to cigarette smoking or other confounds. And another page on this is the effect on brain structure in the developing brain. For several years, neuroanatomical research has postulated that there are alterations in hippocampal volume. Dr. Girdman told us about this 2 days ago. None of these studies allow a conclusive distinction between the role of cannabis use as either a cause or a consequence of brain abnormalities. So the authors of this paper back off to say that, we don't know if this is the cause or effect. Hippocampal volume changes are proposed, and there is a lot of ongoing research. This is a lot of money for the big universities. These MRI scanners are very expensive to operate, and they can look with detail that they've never been able to do before. And they are suggesting that there are very subtle differences. Well, the hippocampal volume changes there was cold water thrown on that recently, just last year, by the Kunder group in Amsterdam, saying that no significant gray matter changes were observed in cannabis users in a 3-year longitudinal study of cannabis smokers and controls. So as much as there's this desire to show harm in brain structure, there's as much evidence out there and recent evidence to show that it just isn't so. And then the NIDA director is often quoted with her surmised neurotoxic effect of cannabis on the developing brain that permanently lowers IQ. This came out of the study in New Zealand some years ago that you've heard about in the last 3 days. This study, reviewed at the University of Oxford, finds the conclusions premature in light of likely confounding from socioeconomic status. So again, tease apart the study and you can explain it in a different way. Usually the conclusions are set about the time that the money is allocated to go to these studies. And when they get the information in, almost doesn't matter what the results are. They've already got their conclusions. So in this case, here we had a University of Oxford group say, nah, you can't really say that this is from the marijuana. It may very well just be the socioeconomic status of these kids being evaluated. What about addiction? Well, cannabis dependency syndrome is postulated with an often quoted incidence of 9% of ever cannabis users becoming dependent at some point on cannabis. Budney is one of the drug warriors in the NIDA group that is constantly publishing information about addiction. This figure must be tempered by the fact that the majority of patients admitted to substance abuse programs are there by legal mandate as an alternative to prosecution or incarceration. What would you choose? Would you rather go to jail, or would you rather go through a treatment program for a few weeks? So that's why they're there, and the majority of the people in these treatment programs are there by legal mandate, not because they're worried about their use of cannabis. I did talk to a specialist, an addiction specialist, just a couple months ago and said, do you really think this cannabis dependency syndrome is real? And he wouldn't really admit that he thought it was real, but he did say that there are some people that want to stop using cannabis on a regular basis. So that was his fallback, was some people want to stop using regularly. Well, it really depends on the rest of the picture, in my opinion. If you're treating a chronic severe condition, regular use is welcome. And if you're impaired and dysfunctional with your chronic use, then it may be appropriate to taper off and use it less. So I think these The authorities point out that cannabis has a drug abuse liability actually lower than other legal and illicit drugs. This is well seen in the literature, and I'm certainly not seeing it in my practice after all these years. People just don't come to me and say, I've got a problem with the cannabis. It's not what I'm hearing. I thought this was worth looking at. This is again from Budney, 2007. And look at the way these admissions to the programs go as far as the diagnoses. In the 12 to 17-year-old group, almost everyone's there for marijuana, mostly because it's easy to find it. First of all, it's still going to be lingering in the urine and the bloodstream for a while, and that cocaine, heroin, and alcohol are gone after several hours. So it's easy to bring people into these admission programs based on drug testing. But look at the way the blue columns go over these intervals of time. Cannabis is not what I would see as an addictive drug by virtue of the fact that this is steadily diminishing as people get into their 20s and 30s when they really have more responsibilities in their life and their use is different than it was as a teen. And on the other hand, look at these more dangerous substances of cocaine, heroin, and alcohol, which continue to ramp up in this population of people admitted to the addiction programs. Psychosis and schizophrenia. You've heard several things about this over the last few days. I think there's one study that came out of England. It was published in 2009, and it was at the Keele University Medical School, and it kind of sums it up in my mind. Assessing the impact of cannabis use on trends in diagnosed schizophrenia in the UK from 1996 to 2005. So for a decade, they're looking at 2.3% of the UK population as they came through the clinic system. And during that time, they were looking for schizophrenia and psychoses. Almost 600,000 patients per year were seen in their clinic system in England, Wales, Scotland, and Northern Ireland. Now, during that decade, there was a four-fold increase in the use of cannabis in the general population and an 18-fold increase in the use of cannabis in the teens, 18 years and younger. So with an 18-fold increase in the use of cannabis in these teens, you would expect to see a marked increase in the incidence of schizophrenia and psychosis. That is simply not what was seen. The incidence and prevalence of schizophrenia and psychosis were either stable or declining during that decade of 1996 to 2005. I mean, an epidemiologic study doesn't do everything, but it's pretty compelling to be able to look at this information and say, we're not seeing what they're worried about. Fetal and neonatal harm, a couple studies that I've cited here, the maternal marijuana use and adverse neonatal outcomes. The conclusion was maternal marijuana use during pregnancy is not an independent risk factor for adverse neonatal outcomes after adjusting for confounding factors. And in another study in the American Journal of Obstetrics and Gynecology, the impact of cocaine and marijuana use on low birth weight and preterm births. So they wanted to go specifically at the low birth weight and specifically with respect to the cocaine and the marijuana use. And their conclusion is that marijuana use was relatively common and was not related to adverse pregnancy outcomes. It was the tobacco is still the most commonly abused drug during pregnancy and associated, as you all know, with lower birth weights. So this actually preceded by Melanie Dreher's work. Melanie Dreher is a PhD who went to Jamaica in the 80s, and she followed kids there. She found 30 pregnant moms and followed them with 30 control moms. And the 30 pregnant moms that were heavy pot smokers were who she really wanted to see how their kids fared relative to the moms, the pregnant women that were not using cannabis. And this is more detail than you need to see, except the conclusion was that the absence of any differences between the exposed and the non-exposed groups in the early neonatal period suggests that the better scores of the exposed neonates, I should back up a step. When she looked at the newborns, they were doing fine. The newborns, the offspring of the moms that were heavy pot smokers. And that at 1 month, at the end of the neonatal month of age, they analyzed all these kids as well. And they found that the ones that were from the moms that were the heavy pot smokers were actually seemed better. They seemed more alert and more responsive, and it wasn't so hard to get their attention. So this is what is being referred to here, that the better scores of the exposed neonates at 1 month are traceable to the cultural positioning and social and economic characteristics of mothers using marijuana that select for the use of marijuana, but also promote neonatal development. A lot of circuitous kind of language, but I think the thing to really note is that when Melanie Dreher had her first study published about the benefits that these kids showed in 1994, she went back 6 years later to look at these kids and see how they were doing. The offspring of the marijuana heavy pot smoking moms were still doing better. And so when she wrote that up and went to Pediatrics magazine to have this published, they dismissed it and said, this is the Earth Mother syndrome. These just were better mothers. So they didn't want to publish it, and so that information never got out in a literature such as this. Dr. Dreher did publish it, though. So on the future of cannabis medicine, cannabis is playing a difference and is likely to continue to play a role in the world of mainstream medicine, with or without federal prohibition. To receive regulatory approval, any pharmaceutical must attain proof of biochemical uniformity, stability, along with safety and efficacy as proven by randomized clinical trials. We've been talking about the RCTs now for days. RCTs for beneficial effects of cannabis are controlled in the United States, you heard this earlier today, by the NIDA, the National Institute on Drug Abuse, the DEA, the FDA, the Public Health Service, and the Health and Human Services. And quite honestly, I believe that this goes all the way to the ONDCP, which is the Office of National Drug Control Policy at the White House. So this is quite well orchestrated. And, you know, from my viewpoint, it may be 50 people in Washington, D.C. that are keeping the prohibition in place. It doesn't take people all through these agencies to believe that cannabis is really dangerous. It just takes key people saying that we're not talking about it, we're not going there. And so when it comes to asking for controlled studies to get the RCTs, they're just not being given to people wanting to do clinical trials on cannabis. It's not happening. But the world is changing nonetheless. And this map is showing you the most recent information that did come out in this same document from the National Academy of Sciences, Engineering, and Medicine in January. You can see that the darkest states there, California, Washington, Oregon, Nevada, Colorado, and then up in Maine and Massachusetts, all have approved medicinal and recreational use of cannabis. The orange ones are limited medical access, meaning low THC and high CBD, whereas the darker reddish color is medical marijuana states. And then we have a few states, very few now, that actually have no medical use of cannabis at all. What's changing the world is the moms and pops and patients around the country that are talking to each other about what the truth is about the cannabis. And that has been leading to both ballot initiatives that the public has been able to generate, and in some cases, legislation that is written by the state houses. I believe that the state of Maine actually wrote their bill and it was voted in by their public, so that these laws are changing around the country, and despite the efforts of the federal government to stop the spread of marijuana usage, it is coming state by state. Now, I want to get back to this a little bit, and I mentioned my concerns with it. This is from, again, the National Academies of Sciences, Engineering, and Medicine. It was published in January of 2017. I know some of the authors. They're good people. But the way that they structured this paper, this booklet, I should say, almost 500 pages, it was really designed to not show the benefit that I see as a clinician. The committee conducted an extensive literature search on about 24,000 abstracts, And then they reviewed the primary research published between January 1st, 99, when that previous book came out, and August 1st of 2016. So now they're limiting to a specific time frame, and earlier research was discarded. Even if it was very positive, it was discarded because it was outside of this 17 years or 16 years. They limited the articles to the English language, so anything that was coming out of Hungary or Spain or wherever in the world was excluded simply because it wasn't in the English language. They refused to look at case reports, editorials, or studies by anonymous authors, or conference abstracts, or commentaries. So again, narrowing the acceptable literature that they would be reviewing. 10,700 articles were reviewed for this report, and only fair and good quality reviews were considered. So now we have a value judgment by these authors who looked at it and said, I don't know if this is such a good quality study, so it may be discarded. So again, more and more bias, the opportunity for more and more bias comes in. The committee recognized the possibility that literature was missed because of the steps that they took to narrow the content. Now, in this book, the first 84 pages are about introduction, history, regulatory, and policy landscape. The next pages up to 140 are the therapeutic effects of cannabis. And then they go into the long list of health effects. So this is where the money goes. This is where the studies are actually being designed by the National Institute on Drug Abuse. So risks of cancer, risks of cardiometabolic risks, respiratory diseases, immunity, injury, and death, perinatal risks, psychosocial, mental health, and so forth. This is what the bulk of the book is really designed to evaluate. And then the end of the book, it's the barriers to cannabis research to be evaluated and some recommendations to research, which are not altogether wrong. It's just that the focus, again, is on cannabis as a drug of abuse. In order to really do this justice, we need to scrap where this is coming from and start with a new system, which is looking at cannabis as a medicine rather than a drug of abuse, and change the focus so that we can design the studies with that in mind rather than an effort to show harm. So the way they divide it up then is to say that conclusive evidence and substantial evidence both are strong papers indicating that this is evidence that is more than substantial. Moderate evidence, meaning there may be some papers favorable to cannabis use, but there might be somebody that produced a paper that was negative. So once they have anything negative, then it can't be in this substantial category any longer, and it falls into moderate evidence. Limited evidence is considered weak. Again, this may be some papers showing benefit, but others showing a lack of benefit. This again fits very nicely with what's coming out of NIDA, where they put tons of money into trying to show harm, whether it's accurate or not. And then there are no or insufficient evidence. So when Simon was talking about the National Academy of Sciences report, he was looking at conclusive and substantial evidence for certain conditions, and it was 3 conditions that qualified: chronic pain, antiemetic, and appetite, and I'm not sure, let's see, it was antiemetic, substantial, and the MS spasticity. So these were the categories that actually made it through the gauntlet and had papers that were sufficient to get through the criteria. And so the way that it would be worded is right there at the top. There is substantial evidence that cannabis or cannabinoids are effective treatment for such and such. And again, I throw some caution to this information because cannabinoids often get down to single molecules. And when we're dealing with single molecule THC, we may be quite biased in the kind of information we're getting out of it because THC alone is not really the product that we want to use in most cases. It's the whole plant, and it behaves quite differently. So the rest of the list includes chorea of Huntington's disease, Parkinson's dyskinesias, dystonias, dementias, intraocular pressure and glaucoma, traumatic brain injury, abstinence and addiction, anxiety and social anxiety, pain and depression in multiple sclerosis, sleep outcomes, and PTSD. And you'll see really in all of these, there was not very strong evidence. I would say that this is bunk. I've been in practice for all of these years, and people come to me all the time with these conditions and are benefiting consistently with it. So I just have to say that as much as I value the effort of the federal government to put something together that shows that we have an opportunity to improve our research, I'm seeing that this is really kind of a stall tactic to not make any changes. And it's quite saddening, because the fact is people are benefiting from all of these conditions, and we just aren't really looking at it in a way that deals with it fairly. What is valid and acceptable evidence? Well, again, we've talked about the randomized controlled trial. I speak of clinical observations. Now, Dr. McArea founded the Society of Cannabis Clinicians, and he repeatedly brought to our conversation the conflict between this gold standard of the RCT and the clinical observation and experience of the physician. The RCT was ushered into medicine in the 1940s, while the time-honored clinical observation has been assigned as anecdotal and invalid evidence. The value of the randomized controlled trial depends upon the study design and what the study intends to demonstrate and who's funding the study. I mentioned yesterday that 55,000 people died using Vioxx, a COX inhibitor for anti-inflammatory uses. It worked great for inflammation, but it also killed an awful lot of people before it was removed from the market. Again, RCTs are used in bringing evidence to the FDA to get these drugs allowed, and then they may be very dangerous, in fact. The value of the clinical observation, on the other hand, hinges upon the expertise and reliability of the observer. So, both are subject to institutional and personal bias. I don't think we should be discarding the observations as insignificant. When the docs stand up here and tell us the stories about the cancer patients and the relief that they're getting with nausea and vomiting, these are real and valid observations and should direct our policy, rather than waiting decades more before we actually have these papers that may eventually come that can prove with randomized controlled trials what we are learning day by day from the clinical uses of cannabis. The federal government continues to refuse research on medical cannabis. Marijuana's safety hasn't been demonstrated through the federal regulatory process. This is a quick line that comes out as soon as we push for the use of cannabis as medicine. There's a couple things that really highlight what was going on in the NIH. And in 1992, the American Academy of Ophthalmology's Committee on Drugs concluded that there was no scientifically verifiable evidence that the use of marijuana is safe and effective in the treatment of glaucoma. And this is my added bold. The Academy could not support proposed legislation to transfer marijuana from Schedule I to Schedule II of the Controlled Substances Act, thereby allowing marijuana to be studied for treating glaucoma. This group actually was responsible from early research in the 70s, showing that cannabis did lower intraocular pressure. They knew that. They said that it was limited to about 4 hours before it faded away and the pressure went back up. They knew nothing about the neuroprotective value of cannabinoids in cannabis, so they didn't really do any tests designed to try to show benefit in using cannabis for glaucoma. Then 5 years later, similar folks at the NIH, at the National Eye Institute, said that none of these studies demonstrated, looking back at those studies, that marijuana or any of its components could safely and effectively lower intraocular pressure, here's the clincher, any more than a variety of drugs on the market. So here they are protecting the pharmaceutical industry. The drugs are available, the surgeries are available. But as far as allowing research into cannabis or really looking at it as a drug that may, or a medicine that may protect the eyes, they don't want the competition. With the embargo on clinical cannabis studies, cannabis clinicians rely on our clinical observations and the basic science. Some of it's animal research, some of it's research on cells in test tubes, but it's what we have to look toward. This is our focus, and for our education and our research and the development of treatment plans, this is what we're using because we can't find the clinical trials that we really want to see done. The opportunity to publish clinical findings hinges upon the requirement for RCTs, IRBs, and peer-reviewed studies. Well, we've got a problem here. Who are the peers? We don't really have any peers as far as the cannabis clinicians are concerned. It's you guys and us who are actually doing the work. And what about the RCTs? We're not allowed to do the RCTs. And what about the IRBs? We might be able to get an IRB, an institutional review board, to say that this study would be ethical. So there's some narrow opportunity to be able to do some studies. It just takes time and it takes money, as you've heard about. The Society of Cannabis Clinicians created our own journal because this was a way that we could actually publish our findings. So OShaughnessy was published the first time in 2003. It was named for the Scottish physician William Brooke O'Shaughnessy, born in 1809 in Limerick, Ireland, and educated in Scotland. And then he went in 1833 to the British East India Company, and there he studied and published on the therapeutic effects of cannabis until he returned to England to introduce Indian hemp, or gunja, to England in 1844. This is just a kind of a poor quality picture of the front page of the Provincial Medical Journal in 1843, talking about Indian hemp and gunja, how to prepare it, and all the things that he had learned that it was beneficial for. So when the Society of Cannabis Clinicians first started getting together in the year 2000, we went to a nursing home where we were given a room to sit in, and we sat round table and talked about our experiences. What was it that we were actually seeing? And among those were the experience that we were all talking about, among others, was the use in Crohn's disease. Well, Crohn's disease is a really difficult disease, and we decided as a group that we would study it and publish our findings in O'Shaughnessy's. So here's Todd McArea smiling with the first issue of O'Shaughnessy's in his hand. And then ever since then, every issue, usually a couple a year to begin with, and then more like annually since then, we've been publishing relevant stories about the science and our clinical observations. So on the right, you see Cannabis as a Substitute of Alcohol, 2003. Going on forward, we have Ricky Williams protesting the use of all the drugs that he was asked to take as a professional football player. He's going on a speaking tour around the United States with other NFL players now, really shredding the NFL for their insensitivity and lack of concern about these guys that are playing football. And he talks about the drugs that they are being asked to take, the opioids, lots of opioids, lots of antidepressants, lots of drugs of all kinds in order to keep them on the field. And once they fall out and are no longer able to go out on the field, they're discarded. So he's up in their grill as far as saying that this is wrong and we really need to allow the use of cannabis in the NFL. In this paper too, we talked about the cannabinoid antagonist will be sold as a diet drug. This is when rimonabant came out. And in 2005, when we met in Italy to talk about, it was an ICRS meeting, an International Cannabinoid Research Committee meeting. And we got together, and after the meeting, we sat round table. Actually, I wasn't invited. It was Fred Gardner who got us invited, but these were the people at GW Pharmaceuticals and others that were very excited about Sanofi-Aventis, who was going to release rimonabant as a CB1 blockade because this was going to work as a diet drug. And you know the rest of the story. It has been released in many countries. It was followed by depressions and suicides. They sent the drug down to MD Anderson Hospital in Houston. They gave it to mice and tumors proliferated. So it was eventually taken off the market, but we were cautioning people back at this time as to the risks of taking blocking the CB1 receptors. We didn't know enough about it to be blocking the CB1 receptor. We talked about the Center for Medicinal Cannabis Research, which had proposed 18 California state-funded studies that were in the pipeline. I think 15 of them may have been completed, but they had a lot of trouble getting people into these programs because of the quality of the weed and the severity of the illnesses that they were dealing with. So suffice to say, it was, as much as that it was a good idea and funded with millions of California taxpayer dollars. That's why these studies actually got through the FDA, the DEA, and so forth, was that they put up enough money to get these studies underway. And it was based at a university, the University of California in San Diego. Other studies. Here's Tashkin's study. Smoking cannabis does not cause cancer of the lung or upper airways. And on the right, in our first report, cannabis alleviates symptoms of Crohn's disease. So we began to talk about our pilot study of 12 patients with Crohn's disease, and it was quite dramatic as to the benefits that these patients were getting. We talked about marijuana and impairment, and we listed with the ICD-9 codes the chronic conditions that cannabis was being used for by the doctors in the society. Going forward, we had cannabis as a first-line treatment for childhood mental disorders. Again, this dates way back, as well as cannabis for post-traumatic stress. So we've been talking about this and sharing our experiences for many years, and this is really why we love the union of physicians in Australia as well as anywhere in the world to be able to share what we're understanding about cannabis. Marijuana in California, we had a 1-decade evaluation of a group of doctors within the SCC, and we talked about the top 10 kind of cases that we were seeing in our practices. So this issue is available, as really all of them are online at this point. Here's our reporting about Meshulam and talking about cannabidiol quite early on. Here's Sean McAllister talking about CBD as a treatment for breast cancer and terpenoids and the entourage effect when Russo first came out with that report. Cannabidiol as a treatment for acne and other skin diseases, and how the skin is rich in cannabinoid receptors, giving sense to the fact that cannabis works for so many skin lesions. And here's our wish that cannabis specialists agree on a health history questionnaire. I say with a smile because it really is not so easy to get people to agree on any kind of a questionnaire, but if we did have some form to the way that we follow our patients, we could share data on patients much easier, and I think this is one of the goals of the society. Doctors stress the need to document anti-cancer effects of cannabis oil, and I'll show you an updated picture like you see here in a few minutes. And then cannabis use in adolescents for self-medication and anxiety. This is a paper by Tom O'Connell. Tom was a surgeon who went into cannabis medicine and specialized in the teens. And he found that the one uniform thing about all these kids that were coming to him with need for cannabis, they might come and say they've sprained their knee or hurt themselves in a skateboard injury, but when he really got down to the details, these kids were troubled kids. They were living in broken families. They didn't have their natural parents around. They might be with grandparents or friends, and they were just troubled kids, and cannabis has given them a lot of comfort in their lives. And I think from the research shown in that earlier paper I was talking about, they grow out of this. It's not something to be feared. We reported on the potency testing and the ring test that was put up by NORML, the National Organization for Marijuana Laws in California. Sent out samples to 10 laboratories around the state and then wanted to know how close they would come. So there was a bell-shaped curve, and the outliers, it was hell to pay. People lost their jobs if they didn't test within a close, narrow limit of what the numbers were supposed to show. Here's cancer and nutrition and other papers that are valuable for the cannabis clinicians. So this is a case that we reported in O'Shaughnessy's. It was one of my kiddos that I took care of. He was 16 months old when his parents brought him to me in August of 2011. And you can see by the columns of the images, these are the images of the tumor, the big bright white tumor in the middle of his brain. The surgeon said, can't touch it. The radiation oncologist said, we've got a treatment for you. The oncologist, the chemotherapy oncologist said, we've got a treatment for you. And the parents just kind of backed off and said, thank you, we'll get back to you, we'll think about this, a lot to consider. And when they really pressed the questions, the surgeon said, I'll destroy your kid's brain by going into that deep place to try to remove the tumor. And for the radiation docs and the chemotherapy docs, they admitted that there would be irreparable damage to the brain to treat this tumor with the drugs and the radiation that they were offering. You'll see 3 months after, we began solo treatment with cannabis oil. So we took the full extract oil. At the time, it was a THC-rich oil. We squirted it onto his pacifier and popped it into his mouth. So he got it twice a day, late morning for his morning nap, and again at bedtime to sleep all night. And then after 5 months, you can see the middle column. The tumor is almost completely gone at this point. And he has remained tumor-free since that time with little vestiges of brightness that you can see in the mid-right column. That may have been tumor. It's hard to say for sure, but the tumor has not regrown. The child is now a first grader. He went through some testing when they got to the first grade because the parents were very interested to just see what the IQ was. And his IQ tested at 135, and everybody's comfortable with this kiddo. He's a brilliant little boy. He's still on his nighttime dose of mixed THC and CBD concentrated oil that he takes every night before bedtime. We're not comfortable with just going without therapy altogether, but we're not seeing harm either. So this is another one of those cases that, similar to what you've seen already, where cannabis as a solo act has really made the difference. Well, actually, this may be the only patient as a solo act. The other cases that you've been hearing about are using conventional therapies, surgery and chemo and so forth. This kiddo only got the cannabis oil. And again, in OShaughnessy's, I published the data that we gathered on our Crohn's disease patients, and I'm going to review that further here. We know that cannabis does, CB1 activation does all these things listed on the left side by decreasing stomach acid secretions, gastric damage, gastric emptying. It lowers this esophageal sphincter relaxation, which is a circuitous way of saying it prevents reflux. And it reduces intestinal motility and secretions and pain and inflammation when you activate the CB1 receptor. And similarly, the CB2 activation results in a lowered pain and inflammation and slows the motility. In Crohn's disease, this is very important. The things that we asked the patients to respond to were pain on a 0 to 10 scale, appetite, nausea, vomiting, fatigue, stools per day, depression, their activity level, flare-up frequency and severity, and their weight in pounds. And so each pair of columns represents each of the 38 patients in the study. This we published in 2005, 5 years before the other publishers around the world began to publish about use of cannabis in Crohn's disease. So you can see here that overall the number of stools per day was markedly diminished from a mean of 5.5 to a mean of 3.7. This is significant in people with Crohn's disease. They don't have the urgency. They can get out and go on their shopping errands and don't have to think quite so much about going from bathroom to bathroom in their lives. We looked at their pain scale and everything was markedly improved. Well, all but 2, I should say. So pain went down considerably. Appetite went up considerably. You notice the p-values on all of these are less than 0.001, which is of high significance. Nausea was markedly downregulated, as well as vomiting. And fatigue was downregulated as well. Not every case, so I can't say exactly what may have been different about case number 6, but there were a few cases where it didn't seem to make a difference in fatigue. I believe there was a paper in Australia about 20 years ago showing that fatigue was a major problem in Crohn's disease. And so I have to say that to see patients finding benefit in cannabis for fatigue is important and impressive to me. Look at depression. I mean, this is kind of a no-brainer. When I show this to a psychiatrist, he says this ought to be presented independently, published independently, because they don't see these kinds of results in antidepressant drugs, where just about everybody is responding with a significant reduction in their mood, in their depression. Activity level is up, again, attesting for the fact that when you use cannabis, you're not in couch lock and dysfunctional and impaired. You get up and go, even at high doses. Most of the people in this study were using smoked cannabis as their preferred method because the data was gathered up until 2010 when almost all of it was smoked, some vaporized, and only a trifle was being used orally at that time. And again, it was almost exclusively THC-rich cannabis as opposed to the cannabidiol and others. So we're contemplating going back and looking at this population of people again and seeing where they are today as an extension of this in a longitudinal study to see how these patients are doing. Look at the flare-up frequency and the flare-up severity, also showing a marked reduction with the use of cannabis. So if we get down to the things that the patients say about it, it's quite telling as to how important it is to them. I won't read them aloud, but you can scan over them and get an idea as to what was said, not only in these 11 write-ups of these 38 patients, all the patients said the same thing. They all benefited in with these same sorts of comments. So in conclusion, I want to put another plug in for the clinical observations. These are valid and legitimate observations that we need to share with our colleagues, share with our governments, and really demand that in the absence of the RCTs, we need to be able to look at clinical observations as relevant information for not only the safety but for the efficacy of cannabis. We have an institutionalized bias against cannabis worldwide, not only in the United States but here as well, that requires both public and professional pressure for more cannabis and cannabinoid education and really a responsible approach to the development of cannabis as medicine. So again, I would conclude by saying, let's avoid blaming the shortcomings of our society on the use of cannabis. So thank you all for your attention.